in contrast to kind of the old way of treating, which was chemotherapy, chemoimmunotherapy, repeated with diminishing success over and over, we now have so many highly active and effective agents for treatment of CLL that we didn't have before. It's really getting challenging, I think, probably for most general oncologists in particular, to figure out how to select from these treatments and how to sequence them in particular. So we still think that there's probably still a role for certain patients of the right comorbidity and molecular profile of CLL to receive chemoimmunotherapy. It's still appropriate and very active. The BTK inhibitors remain pretty much the go-to agent for relapse disease and can often be used even in the front line for particularly patients with 17p deletion or those with unmutated IGVH and other molecular features such as 11q deletion, which we know has a poor outcome with particularly bendamustine-based therapy. Beyond BTK inhibitors, we know ibrutinib has certain challenges, so there's now the potential to use acalabrutinib in that setting. And beyond that class of drug, we know that venetoclax is extremely active, and with proper sort of dose escalation can be safely administered without really significant risk for tumor lysis syndrome.